and I welcome you all for this session. You are sparing your valuable time to listen to us. Rather than making it a one-way communication, I would like to have a dual communication. Most of you would have heard about terzepatide. So I think rather than the slides, we would be more focusing on discussion, and most of the things are already dealt by Dr. Lakshmi. My talk is mainly on SURPASS 2, and before I begin, this is again a Lilly sponsored talk. The slides are provided by them. So how many of you have actually heard about tirzepatide? Just raise your hand. Almost everybody. How many of you have used it? Quite a few. So as the previous speaker told, it's a dual agonist. Let us discuss the basics of science and then I'll talk about the SURPASS 2 because see, most of us will not remember the data, to be very frank. Only the crux information is what I want everybody to take home, right? That is what is important for practice. So when you talk about dual agonist, everybody of you would have heard about the GLP-1. Can anybody tell me the full form of GIP? Anybody, especially from the back? What G? Any glucose dependent. Very good. A tougher question. Can anybody tell me the older name of GIP? Very good. So we are among the learned audience. So most of the things are already known. So I can rush through the slide. So incretin effect is basically when you take glucose orally versus IV to the same level in the blood. But what is the insulin release, which is higher with the oral as compared to IV? That is your incretin effect. And why does this happen? This happens because there is release of some hormones from the intestine when you take orally glucose, when you ingest orally glucose, and that is what is your incretin effect, and that is what this drug is all about. So same thing we are mimicking, and that is the agonist we are giving, and that is what the increase of insulin release we are getting, and that is how this drug works. As simple as that. So you would be surprised to know that GIP was discovered earlier than GLP. Okay, but we were using just the GLP and GIP. This is the only drug in market commercially available which you can give. And as I teach for DM endocrinology, L for L, GLP is from the L cell and GIP is from K cell. Okay, so L from L. Now this slide is already taken by Dr. Lakshmi. If you talk about GLP, GIP, both will decrease your appetite, both decreases hunger, both gives you a satiety. That is why the patient eats less. Now what is the difference? The difference is on the adipose tissue where your GIP will be acting but not your GLP. I'll come to one of those slides that how it is acting. It increases the blood flow basically, and that is why it increases the insulin sensitivity and it increases the storage capacity, reduces the inflammation. That is how it works. Another difference is on the glucagon, and that is why this GIP was not used much because it increases the glucagon in fact, but that is in the fasting state. In fed state it does not increase. Okay, so that's the slight tricky part here. Okay, regarding the glucagon and the adipose where your GIP would be acting, not your GLP. Now if you talk about this incretin effect, the rise of insulin release with ingestion of oral glucose, that is 45% mediated by your GIP and 25% mediated by your GLP. So the much higher effect for GIP as against to your GLP. And when you talk about tirzepatide, it is more of GIP as against to GLP. The hormone mimics more for the GIP rather than GLP. Okay. So this is how it acts on the adipose tissue. We have receptors for both, and on the beta cell again we have receptors for both. So if you see here, it increases the adipose blood flow. That is how this GIP is acting on the adipocyte, and it increases the glucagon. You can see here the GIP. And regarding insulin, both GLP, GIP increases the insulin release. That is why it is working very well in diabetes, right? But it will not cause much hypos, right? As in fact, if you give in non-diabetic obesity, it will not lead to hypoglycemia, right? So that is how it is acting. Now this slide again has been taken already. The half-life is 5 days. That is why you can give a weekly injection, and it is more of GIP. Okay. Again, it acts on the liver, pancreas, stomach, and it decreases the appetite, it decreases the hunger, it decreases the intake, it decreases the fat in various organs, it increases the insulin, it decreases the glucagon also in the fed state. Now here, this are the SURPASS trial. So this is for diabetes. Can anybody tell me about the non-diabetic, just the name of the trial? Yes. So again, we have good audience here. Most of the things are already known. I think we are wasting time now. Or everybody knows everything. So, so, so S against 2 monotherapy, it was 1. And in 5 also it was against the placebo. But the difference was in the 5th, it was with insulin, with glargine. Okay. And SURPASS 2 is against the semaglutide. Now, can anybody tell me the other trial against semaglutide? A tougher question. Which surmount? So this is for diabetes. When you talk about this SURPASS 2, it is for diabetes. The semaglutide dose is 1 mg. When you talk about the surmount, that is for obesity. So that was against 2.4 of semaglutide. Okay, that's the basic difference. I am covering the SURPASS 2 basically. Okay, 3 and 4 is against insulin. So let us talk about the SURPASS 2. So the baseline was comparable, obviously. HbA1c of 8.3, mean duration of 8.6 with a baseline BMI of 34 with almost 2000 patients enrolled. And as we do for the tirzepatide, you start with a lower dose. Every 4 weeks, you escalate. Within 20 weeks, you will reach to the max dose of 15 mg, 2.5, 5, 7.5 and 10. All those, the things were there. And then MTD, that is a concept which is very important in clinical practice also. That is maximum tolerated dose. So some of the patient will not tolerate higher. Okay, so that is what you do in clinical practice also. This was compared to semaglutide. Now you are comparing here to a diabetic, in a diabetic patient, you are comparing the drug. The upper dose for anti-diabetic in semaglutide is 1 mg versus your obesity, that is for 2.4. So this trial is only for against 1 mg. Okay, this was earlier than the surmount. Okay, so this is for diabetes. That is what I mean, though I am a sponsored speaker, but yes, we should understand the fact. My whole idea is to give you a clear picture. Okay, so these are some things which I think is more important when we discuss amongst ourselves, rather than just discussing, just telling about the slide. That's almost useless for everybody. Okay, that you can go on YouTube and you can see in 2x. So that's useless. Okay, so here we are comparing this. So if you see, what an important interpretation is, even when you're comparing the maximum dose of semaglutide in diabetes versus the minimum dose of tirzepatide, still HbA1c reduction is higher with 5 mg. This is the importance of this slide. 2.1 for 5, 2.4 for 10 and 2.5 for 15 mg. So even the lowest dose of tirzepatide is superior in terms of glycemia to the max dose of semaglutide. Okay, got this? The max dose is only imaginary. No, the max dose in diabetes I am talking about 1 mg. Yes, that's a different thing. That's in trial. Yes. OPSIS trial you are talking about, but that's not a comparison of tirzepatide. So if you see again semaglutide, the sustained HbA1c reduction is lesser than the tirzepatide. And then when you talk about the patient achieving the target HbA1c, so usually we target 7.5, 7 depending on the patient. So whatever you do, 6.5, 7 or even lesser than 5.7, it is higher with tirzepatide as against to your semaglutide. Number of patients achieving that target. Okay. Now weight is another concern which all of us have been discussing. Again here, when you compare the lowest dose of tirzepatide against 1 mg of your semaglutide, the weight reduction is higher with the lowest dose. So even 5 mg was superior to 1 mg of semaglutide. You can see here minus 8.5% weight loss as against to minus 6.7 of your semaglutide. Okay. Same way when you see the mean change, it was with 15 mg 13% weight loss, but this is for the SURPASS 2. When you talk about the longest trial, that is in even non-obese, I'm talking about the SURMOUNT, when they showed that removing the drug in one arm versus continuing in one arm, that trial is the longest trial for 88 weeks, SURMOUNT 4, where you can see a weight loss to the tune of 26%. Okay, so that's the longest trial in all the SURPASS and SURMOUNT. So probably continuing the drug will have more effect. This data is for 40 weeks. Okay, so it's the data stops there. So there you have a weight loss of 13% with maximum dose of tirzepatide, which is your 15 mg versus 6% with semaglutide with 1 mg. Okay. And then the composite endpoint, which was your HbA1c less than 6.5, weight loss of more than 10% with no hypoglycemia, even 5% or 5 mg of this tirzepatide performed better than semaglutide, you can see here. And then side effects are almost same. Everybody of us know those things: nausea, diarrhea, vomiting, dyspepsia, belching, all those things. And hypoglycemia, as I already told you, whether you see GLP or GLP plus GIP, the hypoglycemia almost non-existent. If you're using as a monotherapy, non-existent, I would say. Okay. So in summary, Mounjaro or the tirzepatide, this is the first GLP-GIP receptor agonist and the only dual agonist available commercially, superior reduction with the minimal dose 5 mg, also against semaglutide of 1 mg, HbA1c reduction to the tune of minus 2.5 and weight reduction to the tune of minus 13 over 4 weeks, and if you extend it, it would be even higher, up to 20-25% you can say. But every patient is different. I have not shown the data. Somewhere around 5% patient may not respond. It's not that every patient will respond. Okay, so have realistic goals. Just tell your patient what they should expect, what the data says. It's not, see, it is averaged out. Something like that you can say, let's say COVID has a mortality of 10%. Rough data I'm saying. But those 10% who is dying is 100% dying. Right? So it's medical data. So real expectation should be told to the patient right at the beginning. That way the patient will continue and would be compliant and would be benefited also. You would also be benefited. Otherwise the patient will keep on changing the doctor. That's it. Thank you.